Hi, good afternoon. My name's Tish Stefanutto and I'm the chair of the Airway CICO. Thank you all for coming this afternoon. It's very laudable that you're here at the last session of the first day when it's such a beautiful afternoon. Clearly, quoting from Dr. Harrop Griffith's lecture this morning, you're here because you feel the fear of difficult airways, and so you have self-selected yourself. Anyhow, to allay your fears, hopefully today's lecture component will give you some suggestions on how to manage airway problems, how to assess them, how to plan for them, and how to manage them. It's actually interesting. I trained in the UK, and I had a mentor who was British military, and he always talked about the 7 Ps, which they alluded to today, which was proper planning and preparation prevents piss-poor performance. So hopefully today we will give you some insights into planning and management so that you don't get poor outcomes. We have a very broad section of lectures which look at pre-assessment, airway management, airway skills, maintaining skills, learning skills, because as jobbing anaesthetists, it gets very difficult to learn new skills and to maintain them. And the field's evolving continuously. What was available 10 or 15 years ago when we qualified has now changed. Things like video laryngoscopy is completely changing our management. So we'll look at that. We're also addressing OSA, and we've gone to the very dark side and allowed a surgeon into our midst to discuss OSA with us, because we're looking at solutions and management to prevent perioperative catastrophes with an ever-increasing random population group of undiagnosed OSA patients. Anyhow, before we get started, I've been trying to let people trickle in. We've got some housekeeping. This is the airway session. We are in room 1B. Please see that your mobile phones are turned off. And for those of you who haven't, they've asked me to mention the ASA NSC app that you can get in your app stores. You can log in with your email address, and the password is ASA 2014. We will be taking questions at the end of the full session, but you can also submit questions during the session if you go into polls. Anyhow, I'd like to introduce our first speaker, who is Dr. Pierre Bradley. I'm sure many of you have heard of him. He's the former chair of the Airway CICO, and he currently works, having taken a very circuitous route in Melbourne, where he specialises in neuro, trauma, and difficult airway in complex spinal surgery. He is a senior lecturer at Monash University, and he is also part of the Risk Management Portfolio Anaesthetic Advisory Committee at Epworth Healthcare. Pierre owes it all to another one of our speakers, Colin Marslan, who trained him in New Zealand, where Pierre became involved through a series of happenstance, I should say, in airway training and simulation. And from there, he's gone on to develop an airway app, which you can download for topicalization of fiber optic airways. And he has an ongoing role in teaching and lecturing on video laryngoscopy and fiber optic and surgical airways. In his spare time, he's a very busy taxi driver for his numerous children. I don't know how many numerous. And he's recently returned from the UK, where he took a cultural trip with his 12-year-old son, doing some museums and many local pubs. Anyhow, without further ado, Dr. Pierre Bradley from Melbourne.
Just about make out the slides. I should start off, thank you, Tish. Conflicts of interest. I was listening very carefully to the lecture this morning and then had to go and revise all my slides to get out all these funny transitions and stuff. I'm involved in a number of airway courses which the airway companies provide us on a temporary basis, airway equipment, but we have no financial interest. Tish has already mentioned the iPad app that we have. I'll jump too far, that's fine. Which has been developed by a number of us from around the States. And that was provided by an educational grant from AbbView, or Abbott as it was then known. I have some thank yous to say, or acknowledgements. Chris Bain, who's helped me with a number of my endeavours. Gordon and Keith, who've put a lot of work into the airway assessment papers that we've been trying to write. And then Stuart Marshall, I think, somewhere in the crowd. He's my go-to human factors person. He's just recently done some cognitive aids on CICO from our workshops. So, what's new? It's actually more a thing of what's topical. Ultrasound. It's everywhere. Regional. It's even coming to airways now. It's not been shown to be as useful for predicting difficult airways. There are some studies around that would suggest pretracheal fat in front of the trachea of about 2.8 centimetres may be of importance, but it's not been reproducible. Where it is of use is in obese patients, identifying the cricothyroid membrane, and that, for the sake of interest, is the cricothyroid cartilage. That's the air tissue interface, and those are the tracheal rings. Oh, sorry, back. It's been used by ED for gastric volume, fasting status. It's been used to work out the double lumen tube size from the subglottic area. ICU extubation success rates has been utilised where they've been looking at the amount of airspace on a width basis, of which about 4.6 millimetres between an uncuffed tube and the wall suggests that you can have extubation success, and then there's also a stridor component, which, sorry, rephrase that. The stridor component was what I was just talking about. The extubation success is based on the diaphragm moving up and down greater than 1.1 centimetres, which is really a part of the respiratory function side of things. Nasoendoscopy is also becoming more in vogue in clinics. It's used, William Goldblatt, 2012, was using it to actually determine what sort of anaesthetic technique they would use, identify friable lesions versus non-friable, whether we're going to do normal intubations or awake fibre optics. That's really what's new in airway assessment. Now I'm going to use a case presentation which we're going to go through to discuss things that work well, things that don't work so well, and what we have to do for change. Now, you're on call at your local private hospital. Your surgeon rings you, tells you he wants to do a lap appendix. It's a 58-year-old bloke who's got obvious signs of appendicitis. Oh, and he's a little bit overweight. Now you go off and see him, and you get this sort of view. You can spot he's got a beard. He makes me look slim. And you think, great. Past medical history, he's got some OSA. He's got some fancy numbers which the respiratory physicians have written down. They've also written down he's got a stop-bang score of 8. My learned colleague is going to tell us all about that in the next lecture, so I'm going to move on from that. He's got some diabetes, surprisingly, a bit of blood pressure, hiatus hernia. He's had a spinal fusion. Thankfully, he stopped smoking just recently, about 24 hours ago, when he decided he didn't really like smoking because it was upsetting him a bit much. Airway assessment. Malampati is 3. Environmental distance is 6. His interincisor gap is 3 centimetres. Jaw protrusion slightly undershot at grade C. Can't move his neck back as far as he should be able to. Slightly larger around the neck than I am. But he does have a full set of teeth, which shows some periodontitis. He may not be easy. Now, these are all the plans I can potentially come up with about different options you may or may not choose. And certainly in the case that I was reviewing, they went with the rapid sequence and a hyperangulated blade, the glider scope. And I've just rewritten the chart. Primarily what wasn't on that, which should be, is that in the 2003 he had a general anaesthetic for his PLIF, and he had experienced a bit of a sore throat afterwards. The important part about that, with all the information that's given, is that they've written down he's predicted a difficult intubation and he's probably going to be a difficult bag mask. And the decision is to do a rapid sequence with a glider scope. The next part comes as really no surprise. There's a hell of a lot of writing. And really what you can take away from that, because we know anaesthetists love to write things about airways, is that it's bad. So when there's more than 2 lines, there's a problem. So we're just going to digress a little bit. We'll come back to that case a little bit later on. You can think what you would have done. The airway assessment side of things from NAP4, the biggest contributory factor was poor judgment was identified. The other ones were deficiencies in undertaking or recording the airway assessment. We don't do that here in Australia. We actually do that, or so we like to think. Abnormalities when detected, the strategy adopted was not likely to manage this problem successfully. Or put another way, we recognise a problem, but we don't do anything different. We're doing what we normally do. So, deficiencies. The South Australian study a year or 2 ago showed that 41% of anaesthetic charts weren't compliant with airway assessment, and 24%, or 1 in 4, didn't actually have any airway device documented, whether it was an LMA, ET tube. Going to a European study the year before, probably even more worrying was that there was no airway assessment done in about 40% of cases for a general anaesthetic case, and that was increased to about 60% for a regional case. And there was about 700 participants in this survey, which I appreciate Jentis wrote an article about predicting and futility, but he, at the end of it, said it was worthwhile from a planning point of view. So there are sort of 9 core overriding features which you should be thinking about. Is there a history of difficult intubation? What's the surgery's effect on the airway? How much time do I have to actually get the thing in, or altered cardiorespiratory physiology? What's the aspiration risk? What's the degree of difficulty with bag masking, supraglottic airway insertion, intubation, performing a surgical airway, and what's the extubation risk? Putting all that together in the big picture is going to give you your anaesthetic plans that you're going to plan A, plan B, and that's going to dictate what you do and how you do it. So the modern definition of difficult airways really comes down to these 4 main categories, which we'll look at in turn. The first one is the inability to bag and mask, keeping saturations above 90% with 100% oxygen. It occurs at about 1 in 700 to 1 in 1,500, depending on which paper you look at. And realistically, that's sort of a grade 4 we're talking about, and the HANS grading score. But as you see, that grade 3 is where you require 2 providers to do it, and then you use a muscle relaxant to try and improve the situation. There's a whole range of predictors, most notably beard, no teeth, retronaphia, slightly increased weight. In fact, probably most of our clients, patients are greater than 26 body mass index, or it feels like it, more like 46 in some cases. Age, Mallampati 3-4, OSA, neck radiation, and male. Our case certainly had a number of those. Supraglottic airway insertion is actually getting enough ventilation with minimal pressure. Occurs about 1 in 50 to 1 in 100 chance of actually having problems with seal not sitting right. So it's more common than you think. Predictors again, age. You're going to have difficulty at the mouth opening, can't get more than 2.5 centimetres getting in. Smoking, environmental distance. Poor dentition, male, body mass index again. I'm not quite sure about why surgical table rotation is involved there, but I suspect it's just because it's far away and there's potential for dislodgement. Difficult laryngoscopy. Grade 3 and 4 is considered difficult. That's actually quite important, certainly for some hospitals from a funding model, because they get more money and it means you can buy more equipment. So we're looking into that at one of the hospitals we are, and we're trying to get the documentation so we can actually get more funds to buy more equipment. Difficult intubation is basically where they've had more than 2 attempts, more than one provider, and an alternate device may or may not have been used. Incidence, roughly 1 in 20, to the actual failed intubation rates of roughly 1 in 1,000 from NAP4. Again, the predictors which we all know about: mouth opening, body mass index, malapathy 3 or 4. Not having a trained assistant actually makes it more difficult. Phyromental distance reduced, neck movement reduced, jaw protrusion again, large tongue, and a history of difficult intubation. Combining bag mask and intubation difficulties was a paper that was looking at. What I found interesting that only about 35% met the inclusion criterion and the appropriate airway documentation, again, this is from the States. And it occurred about 1 in 250. Again, what you'd expect: neck issues, age, body mass, male, OSA. So it's sort of becoming quite common, OSA. So it's a good job we're talking about it. We've talked about assessment. We should actually talk a little bit more. You're assessing the whole area and what you have available to you. So difficult airway trolleys are important. You need the right tools for the right job, as one of my colleagues would say. Document produced by a number of people, PS56, listed what was essential equipment. It didn't include video laryngoscopes, but that will probably come on with time. There was a recent survey actually in the AIC just recently, and none of the private institutes in Western Australia, I believe it was Perth, actually fulfil this documents requirements 2 years afterwards. This is what we have at our own base. It's a colour-coded, simplified chart, a combination of pre-induction, talks about supraglottic access, and then what happens, can you wake the patient up or do you go to CICO? The important part is colour-coded because it actually follows our airway trolley, which again is colour-coded, and it progressively gets worse as you go down. So, you know, the red drawer at the bottom's got the CICO stuff in. It's designed to be simplified, so it's not a wide range of choices of equipment. It's got limited appropriate equipment in, so it's simple to use. It's also standardised, so every anaesthetic location within the theatres, the ICU and the ED has this. We're endeavouring to roll out something similar up the road as the private hospital, so we're sort of getting a standardised set, hopefully across town eventually. You've got to know how to use your equipment. That's also important. And I'm going to go slightly off tangent here and just give another case presentation, which was in the analgesia and anaesthesia case reports. And this is a aora straight. It's a supraglottic airway device. And what you can see is a plastic cover. Now, someone actually used this with the plastic cover on, gave the child an anaesthetic, pumped up the inflation cuff, which popped off the solid seal, and then removed it. The girl complained, and then the next day the surgeon found this plastic cap at the back of her throat. So I think there's probably a lack of knowledge in how to use the device there. Video laryngoscopes. Keith Greenland produced a paper. I think Chris Aycott was in the audience as well, was involved, and it discusses about the optimal use of different video laryngoscopes. And simplified is basically it can be split into Mac-type blades, which use a Macintosh technique, hyperangulated blades, which you primarily use a midline approach, and if it's a non-channel device on a hyperangulated blade, you should really use a styleted tube, not a bougie. And the reason for that is you usually watch the bougie go down the esophagus because it's a hyperangulated blade, so you're better off angulating the tube with the stylet to an appropriate angle to make it easier to get in. So, essential tools of the trade. Documentation on this. This is demonstrating direct versus indirect laryngoscopy. So Arnie's one of my ED trainees, Matt's one of my anaesthetic nurses, and I'm having an indirect view of the intubation, and Arnie's doing a direct view with a CMAC. I think that was probably a blade free. And so his documentation is going to be based on the classic grading scoring system, and mine's going to be using a POGO scoring system. You can use a Fremantle scoring system, but you need to make clear that it's an indirect view you have, so there's no confusion. Workforce issues. This is certainly in Victoria, there's been a limited number of public jobs available for the last few years. There's been an element of concern among some of the committees about the participation in out-of-hours rosters and the degree of exposure of the current group of trainees that are now consultants coming out. Certainly in the obstetrics forum, they've actually started putting Tier B accreditation at one hospital. They've providing a logbook evidence, some mentorship, and you can't participate on the after-hours on-call until after 6 months. Numbers that I'm going to try and use to back up the reason why I think this is, actually it's from the last curriculum before the change, but 2008, 2010, Western Australia again, Charles Gardner Hospital, they had a look at what their trainees were doing. And the summarised format was, they were doing about approximately 150 intubations a year, which would equate to about 800, or just under 800 intubations in a 5-year period. The awake fibre optics have actually decreased with time from 2008 to sort of half a fibre optic a year. And that's probably was the advent of video laryngoscopes and the availability. And I just put a comparison of my own ones on for privates, sort of which is half the time. Again, about 3% grade freeze. Now, there is some evidence that would suggest you need about 35 plus procedures to gain competency. And if you assume that difficult intubations occur about 3% of routine adult cases rather than trauma cases, you need about 1,200 intubations to get a degree of competency in managing difficult airways. Colin, I'm sure, will talk more in depth about acquiring skills and maintaining skills. And certainly one way to alleviate the fibre optic side of things is to do some training with benchtop models. One is the Dexter system and the other one is the ORSIM, which is more a scenario-based. Algorithms. We've been working on an ANSCO draft algorithm for a while now, but it incorporates pre-assessment into the component. It talks about pre-oxygenation positioning, and then it also goes down the track of documentation and airway alerts. Coming back to the original case, the bag masking, it's got potentially 4 factors, risk factors for that, 5 risk factors for LMA insertion, 6 risk factors for intubation, 2 or 3 risk factors for a surgical airway. So it's highly probable this guy is going to be difficult on a multitude of levels, such that I would say he actually falls into the unholy trinity of all the supraglottic approaches. And so maybe a rapid sequence wasn't the best idea in this guy. The Canadian Airway Group produced some guidelines last year and specifically anticipated difficult airway. And what it really says here is, do you expect this guy to deoxygenate fast? Yes. Is awake intubation feasible? Yes. There, you should be doing an awake technique. If, however, he wasn't cooperative, you could use the ultrasound, mark out the area beforehand, and possibly do this double setup preparation they talk about. Airway passports is just really a variation on a theme. It's what I do for my patients. And previously, this guy's had a previous difficult intubation. Did an awake fibre optic on him. I had a look. I didn't have a look afterwards. Yeah, I had a look afterwards. Found he was a grade 3B. And I've specifically written a letter to him and his GP. If I'd been thinking, I would have made him get a medical alert bracelet. I forgot in this case. But it's really important for the next anaesthetist coming along. There's some appropriate documentation. And so what's the need of change, or what should we be doing? We should document our airway assessment. It's good medical legally. With the assessment you've made, you should plan your anaesthetic rather than doing what you normally just do. You should document what type of airway you're using and putting some information down. It's rather disconcerting when I predicted someone's going to be difficult to find out they've had an anaesthetic 4 weeks beforehand, to find nothing written other than saturation's 94%. Yeah. And if any difficulties are encountered, it's really important to make sure the patient knows about it, the GP knows about it, and there's a medical alert or variation. So it's useful for future people. Thank you.
Thanks, Pierre. Well, Pierre alluded to OSA, and OSA is becoming an increasing population problem. And today we have Dr. Guy Rees, who, as I mentioned, is a surgeon, which is unusual in an anaesthetic conference, so we're very lucky to have him today. Guy originally is English, but spent time in Hong Kong as a child, and then trained at Guy's in London, where he started his ENT training. In the 90s, he found his way to Adelaide, where he did a fellowship and never left. Clearly, he likes the sparkling Shiraz in South Australia. He took over the department with an academic viewpoint to set up an academic department looking at head and neck surgery and difficult tumours, but has, from his explanation, almost inherited the OSA component of his practice, and now has the biggest OSA practice for surgical management of OSA in Australia, and sets the national criteria, or is involved in the national criteria. He has just stepped down as one of the directors and deputy chair of the College of Surgeons. So when he's not doing that, he does ocean racing. And to quote him, it's not always about the race, it's about the journey. So today we're very lucky to have Guy here to discuss OSA with us, management thereof and identification. Thanks, Guy.
Thank you very much for those kind remarks, and to the organising committee, particularly Tish, for inviting me, to Richard Seminoff for dobbing me in. Thank you, Richard. So I got an anaesthetic background. I have actually given anaesthetic to monkeys and pigs at the RPA in Sydney. When I was a senior medical student, I went over there, and we were practicing at that time to do liver transplants. And so I can tell you, probably giving an anaesthetic to a monkey is the most dangerous thing that I can imagine. Avoiding getting bitten in the process, I think, is the most important thing. So conflicts of interest, none, I guess, apart from the fact, yes, I am a surgeon, and do I actually have an interest in the airway? Yes, I do. Probably slightly less than you in the audience, but I'm verging in that area. As we heard, I've got a particular interest in head and neck cancer and with sleep apnea. I've got a personal database of nearly 5,000 patients I've operated on for sleep apnea in the last 18 years, and they've all been followed up at least on an annual basis. It's probably the largest database in the world, in fact, of continuous follow-up, and that's something which is part of NH and MRC research projects which are ongoing. Now, I think Aretha Franklin ought to step onto the stage at this stage. Okay, we've heard that it's very important that we actually give some respect to the airway, and respect is what we should all give to every patient that walks into the theatre, but particularly with regard to some of our difficult patients to deal with. The other thing is to look around you, and we've got a difficult airway trolley, and within that there should be a little drawer with somebody with a head and neck surgical ability that you can pull out and just drag out of that drawer and say, can you give me an emergency airway, please? But unfortunately, they're not standard on your trolleys. But the important thing is that we've got to work together, because otherwise, if we don't, we're never going to get anything done. So just a little run through a bit about sleep apnea here now and what's actually happening. I apologise if I'm preaching to people who already know about this, but the basic physiology I've put up with this diagram up here, showing a step where we go from no obstruction to partial obstruction, increasingly difficult, and then complete occlusion. I spend quite a lot of my time watching people doing this, doing a thing called a sleep nasendoscopy with targeted sedation using BIS monitoring, and we record videos of this happening. You watch the cycles of this going on, the patient breathing reasonably well, starting to snore, nearly obstructing, stopping breathing, and then the point there is that our anaesthetist says, this is not actually sleep nasendoscopy, it's near-death endoscopy. And so we just watch for a little while, and then the patient picks up and gets going. Now, I've done several thousand of these over time, and with the anaesthetist, we've got to balance with it. But it is a dangerous area to be in. We're intentionally letting the patient obstruct their airway, knowing we can get them back again. But watching this process is quite important. So sleep apnea dangerous, yes. So that rocky knoll out there was a cat actually up there. Looks very nice, but actually is very dangerous. This is the type of problem that we tend to look into. Now, we know that the patients are going to obstruct their airway. There'll be cardiovascular and respiratory physiologic problems that happen from that. And then down the line, things, when this happens repeatedly, cause an ingrained change in the patient's physiology. These are not people with normal physiology. They behave differently to other people. They have increased risks, and at the bottom line, their increased mortality and sudden death is something that we're well aware of. Now, the Deloitte Access Economics, they're used to work out whether you should be paying more tax or should give more money to the government, but this work was actually done looking at the cost of sleep apnea, and it comes to something when we think something's worth a lot that we'll get these people to look at it. This data is a little bit old, and if we look at the underlying prevalence, we can see that sleep apnea is more common in men than women, about 2 to 1 on this study. And if we look at the incidence in men, it's around about 7.2%. Now, that data has been upgraded, as we see in a minute. But just taking that amount of risk into account, so 7.2% of the population with sleep apnea, this is the cost to Australia as a consequence of this. Just in healthcare costs, $818 million. The indirect financial costs, $4.3 billion. 190,000 disease-adjusted life years being lost. And the loss of well-being is calculated at $31.4 billion. So this is actually big money, and it's worthwhile taking some interest in it. It's a major health issue for people to be aware of. Now, South Australia has had a long history of looking at people with sleep apnea, and we're fortunate that we work in a multidisciplinary environment where we have epidemiologists, respiratory physicians, oral maxillofacial surgeons, ENT surgeons, all working together. This study, the male study, was actually looking at an entire population area in the northern part of Adelaide where they were screened for a number of things. Sleep apnea was just one of those things. And when they asked that population, about 11% of that adult male population had sleep apnea. So that's above the Deloitte level already. But then of the remaining people, there were actually a randomized study done where they got people to come in to have a sleep study performed. And the uptake rate of that was very high. More than 80% of people who are invited came for that study. And as a result of that, you can see that the percentage number of patients who have unrecognized sleep apnea is nearly a quarter of the adult male population. That's a lot of people. And I would probably suggest that when you actually start an anesthetic with a patient, your mindset should change from being, does this person have sleep apnea? Or is there any way I can work out that they don't have sleep apnea? And we should start with the concept that these patients have sleep apnea and then work backwards from that point. Particularly if we're looking at an older age group, and particularly in people that are higher body mass index, but don't be swayed by the look of a patient. We've all seen a lot of pretty skinny, healthy-looking people with quite severe sleep apnea. Now, Bustleton is a very interesting place. I don't know if there are any West Australians here, but a very interesting town where they decided they would look at the population there, again, a bit like that North Adelaide population. And now the study data is rolling out to 20 years following the initial review. And this data is something which often scares patients when we tell them, yes, you have sleep apnea, and yes, you have a 1 in 3 chance of dying in the next 5 years as a consequence of your sleep apnea. So this is a real problem. You know, you're looking at a pine box or you're looking at treatment, and you can't walk away without making a decision about this. So that concept, you can see the difference in the survival data. Now, initially, we all thought this would just be because of problems related to cardiac and stroke-related death, but in fact, things like cancer-related death, you can see that's increased. And we come back to that issue about what happens at night time when patients are obstructing. There's an impact on their immune system functioning, and their ability then to immunoregulate processes which lead to cancer is affected by this. So it's a big problem. It's not just in our area of the world, but in America. This long-term study from Wisconsin also found the same thing, that people with sleep apnea have a much higher rate of all causes mortality, about 3 times increase. So the problem we've got is that we've got this unrecognised sleep apnea problem in our surgical population. When the patients come to hospital, we don't know that they have that unless they volunteer that they have been taking management for their sleep apnea, they're on CPAP. If they're not on that, which as I pointed out is a large proportion of the population, there are issues related to how we're going to manage them, both intraoperatively, but also really importantly post-operatively as well. And just when that tube comes out and the patient's breathing and recovery is not the end of our responsibility, the problems then flow on for at least 24 hours after that. And it's really important your post-operative plans that you're making for this patient that bears that in mind. If you're writing up heavy-duty opiates for the patient, if you're not organising for post-operative observation to occur, if you're not organising for an airway plan to be made, if you haven't handed over that information to the other people in the team, then don't be surprised if you're going to get the MEC calls and the people bumped down to HG or ICU with a tube in down the track. So it's really important to think beyond the anaesthetic. Now, we've already heard about the NAP4, and I kind of guessed that it would be here. Maybe more interesting that an ear, nose and throat surgeon actually reads the NAP4 stuff, but the reason that I found it interesting was about 40% of all the airway problems were ear, nose and throat related. So we're a major contributor to your problem, okay? And I think that's really important. We take responsibility for that. We've heard a little bit about the importance of looking at the airway. We almost always will have looked at the airway ourselves. And one of the things that when I go into a theatre with Richard or with Deb Knight or Steve Kinnear and Simon Macklin, who are in the audience around here, I will say to them, I've looked at this guy's airway and this is what I found. We may even show them a video of what we've seen, but we talk through what the patient looks like when they're awake, and there's some knowledge which is being transferred. Now that's a really good situation, but most patients come to theatre without any of that. But I do tend to deal with people with more difficulty with their airway. Now I'm not going to go through all of the models which are in here, but I just put up a few which I was reading about and the outcomes that happened. And the interesting thing is we were hearing from Pierre's talk was that this NAP4 was predominantly pre-video laryngoscope era, and often the patients would go from not being able to be intubated or ventilated, and then attempt at things like needle cricothyroidotomy in people that were not skilled and trained in that area. I would like to see that everybody who has an interest in the airway knows how to manage people in all those plans. Only 2 weeks ago, I had the situation, I got called at home about 9 o'clock at night. There was a registrar surgeon, a registrar anaesthetist, and somebody with a bowel obstruction who they were trying to intubate with a fixed flexion deformity of their neck, vomited their secretions into their throat and aspirated it, calling out if I could get down there to give the patient a surgical airway. There was a surgeon in that theatre, a general surgeon. I arrived there 15 minutes later, having asked them to get that airway organised to find a dead patient in theatre, and everybody very upset, but not a scratch on the patient's neck. So I think we have a responsibility to think through all the plans and make sure that you don't stop just because you can't get the tube in through the mouth. So as I said, this is the pre-video laryngoscope audit. I don't have any links to GlideScope, by the way. I just put this slide up here. But the things which I find interesting, and I've videotaped our anaesthetists watching them whilst they're doing this. So they get a video of the actual airway, but I video what they're doing. And that's actually more instructive, I think, about the little techniques that they have when they come to get these airways put in, how they manage the bougie, how they angle the patient's tube, what they do by blowing up the tube in the back of the pharynx and so forth. And these type of things, I don't think most of the junior registrar anaesthetists really know. And so I keep sort of showing them my phone, look at this, let's see what's happening. And then afterwards we do a bit of feedback with that. I think it's quite a useful thing to be involved with. So screening, we'll just come down. This is really what the main crux of this is about. So what we could do is to say, I think you've got sleep apnea. I'll tell you what, I'm not going to do an anaesthetic on you now. You go off and have a sleep study done, and then we'll start you on CPAP, and then a few weeks later you'll come back again and we'll do your anaesthetic. Now, that doesn't really happen, okay? In the real world, the time taken to get through that's not going to happen. And we quite often say, yeah, you've probably got sleep apnea, and I'm going to give you an anaesthetic, and I've got a plan of how I'm going to deal around that. But we very rarely actually stop the whole show and say, off you go and have CPAP. That would probably be the safest thing to do, but it's not what actually happens. So the problem that we've got, as we mentioned, is that we've got issues about intubation, we've got issues about medication, we've got issues about post-operative care. All of those things need to be built into our plan. Type of things that we see happening post-operatively, patients going to atrial fibrillation, other people going to heart failure. These type of things are pretty common that we tend to see in the post-operative period. We can predict these. So this is a meta-analysis looking at all the different ways that we could do this assessment. There are quite a lot of different ways we can do this. And the bottom line is that none of them are actually perfect. And really that doesn't matter. Okay, the important thing is to have a concept that you're actually going to ask these questions. You're going to have an assessment protocol. I don't really mind which one you go for. I don't have a vested interest in any of them. There are some which are marginally better than others. But if you look at one and think, I reckon I could use that, then use it. Keep using it. Stay with it. Get some feedback. Understand what's going on with that. Pick one and go with it. So this is a pretty simple type thing, okay? And I'm sure most people in year one registrar training in anaesthesia will be taught this type of idea. Open your mouth. Let's look at your tongue. Look at the size of your tonsils. See what your jaw looks like. Are you a big guy or skinny guy? These types of things can be helpful. You write all that down in your preoperative assessment. That helps, and that's a good step. And I'd expect a year one registrar in anaesthesia to do that. Now, this guy here, Murray Johns, he's a guy from Australia and come from Melbourne, and he's from Melbourne, the Epworth Hospital. And a long time ago, in 1991, he set up this screening plan, the Epworth Sleepiness Score. And we use this routinely in patients with sleep apnea. And if you're scoring above about 9, you've probably got sleep apnea, which is mild. If it's above 11, then you've probably got moderate obstructive sleep apnea. And if you're above 16, then you've probably got severe sleep apnea. There are other causes for this to happen, and there are some people with sleep apnea that will not report increased sleepiness during the day. They say, yeah, well, I just wouldn't actually go to bed there or wouldn't go to sleep. I've got the kids to look after, or I've got a job to do. So it's good if people think about it in real terms, but it's actually quite often not well reported by the patient. So this is another one from Europe, 1992. It's another questionnaire, quite simple, just a few questions here. The problem was that it had a pretty poor positive predictive value, 25% of false positives with this. You're probably going to overcall the numbers of people with it. This is one of the ways that we tend to get involved with some of our patients. We'll do cranial cephalometry with CT scan and measure angles around their jaw and head area, the size of the airway, and we can give figures, numbers, angles, which give us the likelihood of the patient having moderate or severe sleep apnea. It's not practical, but if you think about the type of things that we're recording here in terms of mandible opening, shape of face, you can see some of these things just looking at the patient. So these are the box element, whereas the Mallampati is more the inside, the soft tissue stuff. So if you look at the box, and the box is small, that's a problem. If the box is big, but they're out of balance with a large soft tissue area. That's a problem. So moving on from that, we now come up to what we want you guys to be doing, and this is a questionnaire type thing. Here's one here, using the Berlin questionnaire, 99, this came out, and what we found was that it was a pretty good way of actually diagnosing people who are likely to have some element of sleep apnea. And it's a very common thing to find that it's positive. You see, about a third of all outpatients going to a primary care physician for any reason would score highly on this, and they've probably got sleep apnea in most of those cases, as we heard from that male study. Now, obviously nobody's going to be copying all this down. This is all basically in that Berlin questionnaire. In this one, the reason why it's a little bit complicated is you've got 3 separate categories to look at, and those categories, you score on each of them. If you score 2 or more on the category 1, 2 or more on category 2, and category 3, if you add those together and you're scoring in 2 out of those 3 categories, then you're at high risk of having sleep apnea. A lot of questions to ask there. Patients often get a bit bored and may not follow that or may not get the idea. The stop bang one, less questions, looks a little bit less crowded on the paper. You can imagine just having a sheet of paper and handing this to the patient. They can fill that out. And that also gives us a pretty good scoring system with that. We can get a pretty good idea whether they've got a risk of sleep apnea, stop bang. ASA checklist. This is, again, reasonably simple, just a few questions to ask, and again, categorizes what's going on. So I would say probably of the questionnaires, if you're going to pick one of them, one of those 3, the Berlin, stop bang, or ASA, probably are about the same in terms of the prediction value. And it depends on what you look at on the page and whether you think that's something you can use. But just pick one of them and you have it printed out 1 million times and then hand them out to your patients and stick it in your anaesthetic record for the operation when they come through the pre-anaesthetic clinic. These are other ones here. Ohio Sleep Medicine does another one. There's a nice little chart system with that. You can ring on the chart where the patient is in that. So these have been validated and compared against each other, and I said the STOP questionnaire, Berlin questionnaire, ASA, they've all got pretty high sensitivity for screening. Of those 2, the STOP and the ASA predicted if you're likely to get into problems post-operatively. This becomes a statistical thing. All 3 of them are pretty similar, really. So just to summarize all of that, sleep apnea is very common, much more common than we realize, more common than patients in the population realize. It's probably at least 25% of males, and it's more in the elderly and more if you're overweight, but not uniquely so in that. But even in women, it may be at least half of that amount, 12 to 15%. So it's a pretty common thing. They do have big problems that you need to look at in the post-operative period. That questionnaire is a pretty simple way of doing it. If you use the questionnaire together with a Mallampati type score, tonsil grading, that would be pretty good. I'd be very happy with that. And at the end of the day, we just want to get in, do our work, go home, and everybody be safe. And if the patients are happy and alive at the end of it, then we're very happy. Thanks very much.
Thanks, Guy. That was excellent. Right. Well, we're in the home straight. Our final speaker is Colin Marslan, who taught Pierre Bradley everything he knows, apparently. Colin is a consultant anaesthetist at Wellington Hospital in New Zealand. His major clinical interests include paediatric anaesthesia and difficult airway management. Last year, he won the NZSA Ritchie Prize for research for his work related to emergency percutaneous transtracheal ventilation. And also in the same year, he co-initiated the Wellington CICO team training on anaesthetized sheep. He's very well known to those of you who do airway simulation for, he's the co-inventor of the Dexter training module that Pierre showed earlier, and is the director of the company that produces Dexter. He conducts proficiency-based bronchoendoscopic airway management training at Wellington, and successful participants get the bronchoscopic driver's license. He's got multiple peer-reviewed articles and publications and is an invited speaker and workshop instructor in several countries. He'll be doing workshops on fibres tomorrow for those of you who haven't signed up. We do still have places. When he's not doing all of that, he is an avid fly fisherman, enjoying the pristine bush-clad headwaters of New Zealand, and a sometime all-black rugby supporter. So without further ado, he'll be presenting mastery and maintenance of airway skills, and also, in that session, looking at an overview of innovation in the CICO scenarios. Thanks, Colin.
Oh, thanks very much, Tish, for that very nice introduction. It just shows you, if you ever write anything describing anything you've done, it can be found on the internet. So I'm Colin Marslan from Wellington, and the declaration, I guess, Tish has made for me is that I'm a director of the company that makes Dexter, and I use them a lot for academic purposes and teaching, and there's also this commercial interest there, which it's important to declare. So the attainment and maintenance of competence in the skills associated with airway management is expected of us as anaesthetists. Fortunately, the clinical opportunity for what I'd consider to be the bedrock skills of airway management is abundant. And I think that's why we're all pretty good at them. I guess SIGs and difficult airway societies and the like are founded because of a tiny percentage of situations where airway management is the airway management required is beyond what this bedrock set of skills provides for us. So this will account for 99% of our patients probably, and somewhere between 1% and 0.1%, we're going to need a slightly different skill set to have a good outcome. Because clinical opportunity is so abundant for this group of skills, we can, when step changes occur, like supraglottic airways and video laryngoscopes, and perhaps not so much the ones with extreme angulation, but your Macintosh and Miller-shaped blades, we can incorporate them with relatively little effort, okay, into our clinical practice. And we do that safely, and we can continue to improve what we do on a daily basis because of clinical abundance. For the small group, that 0.1% to 1% of patients where we need different skills, and really here I'm alluding to bronchoscopic airway management and the skills associated with CICO, with due reference to elective tracheostomy from the little man in the difficult airway trolley, which would be lovely to have, I agree. But for these skills, clinical opportunity is very limited. And on top of that, there are particular challenges associated with each. So for bronchoscopic airway management, I think that's related to the moderate psychomotor complexity involved, and for CICO techniques, it's related to model infidelity. So fibre optic intubation is a recognised gold standard. We all know that. And yet, as Pierre was alluding to, there are still cases described in the literature where it was indicated but not performed with poor outcome. And really the question is, why is the gold standard still used in a patchy fashion in clinical practice? I think a big component of this relates to the fact that there is a psychomotor complexity associated with driving a bronchoscope. and that it has to be learnt differently to the way we learn other skills. There are other skills associated with awake fibre optic intubation, but I think they can be learnt in pretty standard fashion: observation, didactic teaching, more the apprenticeship model, if you like. But the psychomotor training required for this is just a little different. Now, the video you're watching, I don't think anyone in the audience would feel that that represents psychomotor proficiency in driving a bronchoscope, but the trainee involved has attended a lecture on how to drive a bronchoscope and has had access to bronchoscopic equipment and bench models for about a month, and then this is the first couple of clinical passes that have been recorded. So access to equipment is not in itself sufficient to grow the skill. And the equipment, the tools have to be wrapped in structured learning. I think these are the important components of psychomotor skill training. The structure associated with mastery learning, I think, is key. Evidence of clinical transference is extremely important. We often don't think about this quite enough. So what I'm talking about there is that the skills that we're learning on bench models transfer to the clinical environment, but of course they can transfer in positive ways or negative ways. So the clinical transference aspect of things really speaks to model fidelity and the general validity of how we're training. With psychomotor skills, there's obviously a practice requirement, and any sports person will be familiar with that, or musician. And because of that, because the individual practice requirement is different for different people because they have different aptitudes. And so I would suggest that this sort of psychomotor practice needs to happen at a local level, because we simply can't cater for it in the typical workshop environment. You can learn lots of other things, but if there's several hours of practice required, it needs to happen locally. Just pure logistics. Also, this sort of training needs to be largely self-directed. In other words, the learners do the learning. We need to have airway champions, if you like, locally, people who are prepared to facilitate this sort of learning and prepared to get the equipment that's required and prepared to do the assessments that are required. But the practice needs to be done by the learners. And I think this is important if training is to have a long-term future in any place. Cost effectiveness is also important because of the need to have the tools available locally, essentially, not just in ivory towers. It's been well shown that mastery learning in comparison to non-mastery learning is more effective, and, rather than but, it takes more time. The key characteristics here are that it's a very structured, robust sort of learning strategy in which goals are of particular importance. And so there's this idea of deliberate practice where a learner practices to achieve a goal, has to achieve the goal before advancing in the training. And so there's cycles of assessment, of practice and assessment prior to advancing. There's not much actually, there's not many skills that we have where this is really required. Now, the video that you're looking at the moment is me doing a nasal pass with the endoscope with the camera on. In fact, there's two passes, nose to corona, camera on, eyes shut. Now, what does that tell us about proficiency? Absolutely nothing. It takes about 4 seconds to get from the nares to the corona. That's what you're seeing here. And in the previous video, the trainee was taking about a minute to go from mouth to corona. A minute's in the literature is often used as benchmark of success. So if they can do it within a minute, then we'll say they're competent and we'll move on. Completion time in itself is a very poor surrogate for proficiency. And whether it's slow or fast like that, it's really fairly meaningless. My trainees who achieve proficiency in driving a bronchoscope will reach the carina from the mouth in approximately 25 to 35 seconds as a whole. It's a characteristic of the proficient driver, but the time is actually not critical at all. Volume of practice is frequently considered in terms of what it takes to be competent. So Pierre was suggesting 36 times doing a technique. When this study was done in respirology trainees doing a proper bronchoscopy, I guess you could say, at the time the standard was 50. You had to do 50 in training. And so they followed respirology trainees. They did 100 fibre optic bronchoscopies. They showed there was a steep learning curve to about 30. There was significant variation after 50, which tended to become less by about 100. A cohort of them who had a focused period of learning early on had a much steeper learning curve, and the rest of them didn't catch up until about 75 patients. So volume of practice itself, time in the saddle itself, is not the same thing as proficiency. There's an association for sure, but it's not the same thing as proficiency. And so we have to think a little harder about how to measure proficiency in specific skills. Now, the ANSCA volume of practice for our trainees is 3 awake fibre optic intubations. So in terms of competency-based training, I think that number is meaningless to me for these reasons. So some time ago we developed a global rating scale for fibre optic bronchoscopic manipulation. So the reason for, the main thing I want you to see is that there are 4 descriptors here: view of the central airway, mucosal contact, progress, and orientation. And there's a scale along here according to how they're doing. This relates to passing the bronchoscope from mouth to carina in an anatomic model. The video on the right just shows examples of a proficient score, and I use this in teaching. I use this much more as a definition of proficiency. So there's a much more qualitative aspect to this, and this is what the goal is, or aspect of the goal for the sort of mastery learning principled training that I'm talking about. The descriptors for this is that they can't lose view of the central airway more than once, they can't hit anything, and there's general progress, and they're generally orientated. And it's done with recording of a pass in the with the bronchoscope. With all of the camera equipment now, it's very easy to do recordings, you can put a thumb drive into the side of an Ambu A-scope, for example, and that's readily manipulated. And similarly, the new equipment with Storts is easy to use for that reason. It's actually not difficult to record and look it back, and it's quite instructive to show trainees what it actually looks like, and why they're getting the score that they're getting. So a definition of proficiency is important, and it's going to be different for different skills, and the way we're going to measure it in a way that's clinically transferable. This study from a while back basically looks at the logistics required. So we define proficiency. The question is, how do you get there? So how much practice does a trainee have to do in order to become proficient? And this is really determined by an individual's aptitude. Because aptitude varies, so does the practice requirement. And it's really, it illustrates the difference between a mastery approach and non-mastery approach in my mind. So a high aptitude trainee here, after 1 hour of practice, has achieved a proficient score. But there's only about 14% of them. By about 3 hours, we've got about 80-odd% proficient, and 5 hours for, took 5 hours for probably the person with the lowest aptitude to get a proficient score. I'm really, really proud of that individual that bar represents, that effort that was required. But the point is they're all at the same standard at this point. So we've got a uniform standard. It just took some people longer than others. Now the logistics of doing that are such that that's very, very hard to achieve in a workshop. So in a workshop, this high aptitude group are going to come away going, yeah, I've got it, and can take it to work and use it. Whereas the majority of people are going to be short of proficiency, and as with that first clinical video I showed, are going to run into trouble when they try to use it. The blue dot here is a group of medical students, about 30 medical students that we put into a non-mastery bronchoscopic driving workshop, if you like, for 3 hours. So they each had 1.5 hours of practice on a bronchoscope, and then we looked at their performance afterwards, and it sits very nicely in this sort of achievement of bronchoscopy sort of graph here. So about 20% of high aptitude medical students achieved proficiency in an hour and a half. Almost 80% of people didn't, and that's the problem we have with fibre optic training based on workshops, and why I think it needs to be done locally. Clinical transference, I said this is a key thing. This is a key aspect of validity, and when we looked at the people who were GRS3 or proficient scores on clinical volunteers, the clinical transference is 93%. So this skill transfers very well from the bench models that we're using to the clinical environment. So part of the mastery structure relates to staged advancement, and the GRS, as you will have recognised, as a midline manoeuvre and we need to have skills in rotation and oblique movement, obviously as well, to be considered competent in the driving aspect of bronchoscopy. So there are other key features in terms of teaching structure and assessment that come with this driver's license. So it's the driver's license that they're aiming for, and that allows them to do clinical bronchoscopy. So if I just summarise the key points related to this ability to put objects in the centre of the screen and move accurately in oblique fashion. I emphasise the centre of the screen because that's where our bronchoscopes are heading. And that's where you need to maintain midline targets and where you need to move targets that are off to the periphery in order to be able to move obliquely in an accurate fashion. So if you imagine that the solid blue oval is the centre of, that's 3 different screens, and our target is up there, and we want to get into the glottis. Then the first thing we need to do to position our target in the centre of the screen is to rotate it into the 12 o'clock to 6 o'clock axis. Getting right into that axis is the only way that you're going to end up eventually in the centre of the screen. So if you stop at 10:30 or 11 o'clock, there's going to be some problems. So we rotate into this 12 to 6 axis. So we've done that. Oops, beg your pardon. So we rotate into the 12 to 6 axis here. We use the angulation lever to bring the image into the centre of the screen, and there we are. Now, when we advance the scope, we're going to go straight into the centre of the screen, which is where our target is. So rotate, flex, advance. Inaccurate rotation here, if we leave it at about 10 o'clock or so, when that descends, we're in this position and the bronchoscope is going to miss the target. So why is that important? It's important because it means efficient rotation is an absolutely fundamental aspect of driving a bronchoscope well, And so I emphasise, upper hand controls, gripping towards the fingers, the lower hand supporting the bronchoscope but not preventing its movement, and the fact that the hands are connected through with a little bit of tension so that they're moving together. And this combination of things allows efficient rotation. In order to assess, we put a lot of emphasis on teaching people about these little aspects, the little nuances of being able to rotate a scope, because it's critically important. So when it comes, so they're practicing on Dexter, but this is also what we use to assess this rotatory aspect of things. So you can see in this navigation pod that the target has been rotated up to 12 o'clock and then brought into the centre of the screen, more or less, and then there, and then you can advance through it. And it's just the same little mantra over and over again is how you can drive the bronchoscope accurately. It's absolutely the sort of secret to endoscopic dexterity. Similarly, with this rotation pod, it has definite sidedness to it, so they can learn about orientation in front or behind the patient. And also, when I'm watching trainees using this, it's very obvious to see what they're doing with their hands. They're concentrating on the screen, but they may have formed a big loop. They may be squeezing so tight, especially in the assessment phase, with their lower hand, that the rotation happening with their top hand isn't being transmitted. But if they can do this sort of rotation, if they can get round 180 degrees easily without turning their bodies all over the show, then they've pretty much got what's required for proficiency. So the licenses, they need to be GRS proficient with 3 passes, mouth to carina. There's several tasks they need to do in Dexter, which includes those pods, and some anatomic familiarity, so rotating into major bronchi usually. If they can do that, they get their license. So since 2010 to now, I think 75 of our trainees have gone through this. The success rate is 85%. I basically am responsible for that teaching and do it myself. And about 2/3 of them get their license on first attempt. They've done enough practice to be proficient in all of those areas. And 21%, I have to say, look, go away. You need to do another couple of half-hour sessions, another hour of practice. And everybody who does that goes away, does an hour of practice, comes back, succeeds in the end. And I think this is the strength of this mastery kind of structure. There's a small percentage of people that never come back. And in Wellington, you need your license to do clinical bronchoscopy. So the challenges of the clinical exposure to bronchoscopy remain. I don't really have any secrets as to how we can increase, the difficult airways that we have to do proper awake fibre optic intubations for. But elective asleep fibre optic intubation is full of learning, possibilities. So this person who's got their license is, now discovering that that going via the nose, a jaw thrust will provide extra space. It'll bring the tongue forward, the soft palate tensioned, and there's some space to move through here. So a little bit of oblique movement, and then they're through that obstructed curtain. So that's jaw thrust opening and closing the airway at 3 levels. So we're releasing it now, doing jaw thrust again, the epiglottis coming up and down. I mean, it's a fantastic example of why jaw thrust is important in bag mask ventilation, why it's important in the clinical aspects of bronchoscopy. We have occasional access to bronchoscopy clinics, but not nearly as much as I'd like. I know other places have regular access, which is fantastic. Cardiothoracic offers some opportunities, ICU offers some opportunities, but this is still generally a difficult sort of area to get sufficient clinical exposure. But that business of the asleep elective fibre optic intubation, it's quick. And it provides a really good way of people getting some numbers under their belt and moving on. Is there any evidence? Well, this meta-analysis came out in CHEST last year looking at simulation-based bronchoscopy training, and it suggests really that structured training is more effective, if authentic clinical context adds value, animal models and part-task models may be superior to the more costly virtual reality simulators. I mean, this sort of thing's about $160,000 US, and they range from, you know, just screens on computers where, you know, which will have a function, to Awesome, which is a really interesting model that's come out of Auckland, but I think possibly they just we have to work out what different devices do well. What's the point? What are we trying to teach? How do we work out what the clinical transference issues are? Just briefly, as Tish said, we've been doing some. We're learning really about running wet labs for CICO techniques, and I take my hat off to Andy Hurd and his group in Perth. I think they've done an absolutely fantastic job in terms of opening up this conversation and getting people to think about issues related to this. We published this in the BJ this year, which was a good, you know, we were looking at comparing manujets and vent trains with completely obstructed airways, but it was a foot into starting wet lab training, which we combine with bench work and simulation. The reason really to tie this in at the end of the talk is really to talk a bit about model fidelity, and in CICO issues I think this is of particular importance. The fear and anxiety reference from the debate earlier on today sort of resonated because I think that a lot of our enthusiasm really for difficult airway workshops, you know, is to try and be optimally prepared for when the bad thing happens, even though it's very rare. And there's a certain amount of there's nothing wrong with that. But there is potential for negative clinical transfer if what we're learning on models doesn't really reflect what's going on in real life. And so that video is just your typical needle cricothyrotomy, you know, more or less the way Andy suggests, using the Rapido 2 device that the Perth group were very influential in having made. And my concern with this sort of bench model is that it's overly simplistic. The endpoints aren't really realistic. They're particularly good for, you know, the basic mechanics of the technique, and that's very important because if you're moving on to animal models, you don't want to be wasting, you know, an anaesthetized sheep because you don't know, you don't know what happens next after you've picked up the Rapido 2, for example. You don't know where to put the needle. So they have a role, but I'm just a little concerned about potential negative transfer. So when you and this sounds off, so it's, you know, you can have to make that up for yourself. But this is a desaturated sheet towards the end of our PEO algorithm, and this is the last person attempting scalpel blunt dissection technique. The reason to show that really, and I'm sorry if it seems a bit gory to some people, but the reality of putting needles in the airway, the reality of putting a scalpel in the cricothyroid membrane, and then finding that the bougie has dissected outside the trachea or into the esophagus, putting a needle into the airway and it filling with blood, and then discovering that, or putting a needle in it seems absolutely fine, and you're not aspirating cleanly. When we are learning to teach this, and, you know, very much learning ourselves as well, every little nuance that Andy Hurd kind of talks about in his internet publication after 10 years of experience, you experience very quickly. And I just think it's very valuable to realise that what's as easy to simulate is not necessarily easy to do clinically, and I think CICO is a good example of this. It's really just to stress the value of animal models, really. It all ends well. So finally, the hazards of model infidelity is a conversation, that's starting in the literature as well, and I think this idea is worth just thinking about. It can be physical, functional, psychological, but basically we're saying we're learning to do things on a bench in a certain way that doesn't translate effectively to the clinical environment, but it might make us feel better. So there's a lot of things going on with this, but I think it's really just an awareness that we need to be careful about and very specific about what we're trying to learn and what we're transferring to the clinical environment. And a brief example really is virtual reality bronchoscopy works by a surrogate scope sitting in quite a tight orifice, and then it picks up the manipulations of the scope, which is fantastic. And these are pretty awesome devices. One concern I have is that if the tip of the bronchoscope is always sitting in a snug little orifice, then the relationship between the hands and learning to rotate effectively and that sort of thing, or controlling it in the midline in an open space, isn't being learnt. There are some other very, very strong aspects of it. So in conclusion, I'm really talking about skills-specific instructional design, and this really reflects clinical opportunity and model fidelity, and necessarily clinical transference related to that. Where there is significant psychomotor complexity, which is the issue with bronchoscopy, then investment in mastery learning principles, I think, is very important. That means local training to meet individual practice requirements, and I would just urge people to get the hands-on experience themselves in animal models for the excellent work that's going around with CICO. Thank you very much.
Thank you so much, Colin. Now, are there any questions? Yes, sir.
Yes, I have a question for Guy. You made a very interesting comment about putting patients with newly identified obstructive sleep apnea on CPAP masks and getting them back fairly quickly. Is there an optimisation as fast as that?
Yes, as I was saying, I think reality is it doesn't really happen. The ideal thing would be to do that so their cardiorespiratory physiology returns back to normal. And if you looked at about 2 to 3 months of being on CPAP, that would be a reasonable period of time for them to be like a normal response. But most patients that you see, you're going to make a call to say, I can get them through this anaesthetic and mostly you'll be okay. The ideal situation is that the surgeon, before they book them, recognise they have a problem and send them off their respiratory physician first before they even get to the pre-anaesthetic clinic, I think.
Encouraging the 3 months to make such a difference.
Yeah.
Any other questions? Yes.
Question for Pierre. Your patient that you had, you were on 3B after you've done your awake fibre optic. What would you do next time you saw them?
I'll do an awake fibre optic again like I did the first time. A 3B to me is the same as a 4, really. I would struggle to get an intubation even with a video laryngoscope. But my assessment would generally consist of difficulty to intubate, are they easy to bag and mask or not, if I was seeing them for the first time. If I think they're easy to bag and mask, I'd use a video laryngoscope. If I think I'm going to have difficulty, I'm going to do an awake fibre optic. Does that answer the question?
Any other questions? Yes.
Yeah, it's a very valid question. when I put up the slide with the little, the medical students who went to a workshop, that slide, we actually followed that group for 5 months. Half of them did a simulated bronchoscopy every month, and half of them did nothing, and then we just tested them again at 5 months. We kind of expected that the group that did a little bit would maybe get a bit better, and that the group that hadn't seen a bronchoscope for 5 months would probably fall away a bit. What we actually found was that there was no change whatsoever in either group. So, it's of interest, and I think aspects of it might be like riding a bike. I think you might, if you haven't been on your bike for a while, you might just feel, a bit, less confident, and but I think you sort of quickly get your balance and you off you go again. So I think the investment in that initial training, I think, is really important. And in terms of the psychomotor proficiency, I suspect it's just lurking. I think you learn how to do it, and I think you probably, if you learn it solidly, I think that will probably stick with you. But there's a state of mind that we all get. You go on sabbatical for all you do. You go away for a little while. You don't give some anaesthetics for a while. I think we're all a bit nervous for the first few cases, or something bad happens, and you lose your confidence a bit, and that you get a fibre optic under your belt, and you go, I've got it, and it's all right. I can still do it, sort of thing. That study with the respirology trainees, I thought it was very interesting that there was such a marked difference with an educational intervention. So they took one group of them, I think, and put them into some organised, structured training, and then they did their, the rest, the next 80 or whatever it was, 90 bronchoscopies. They were way ahead of the people doing it one by one, never actually getting to the standard. So I think there should be some emphasis on a constant, concerted effort, and it's not that hard, but it can be a bit hard to get the hang of it initially. But I think once you've got it, I think that's sufficient for most of our situations, which for the occasional bronchoscopist is going to be an anatomic rather than a pathologic airway. And once you're in that with a flexible instrument, and you can drive it reasonably well, you're going to be fine. So, and the other question I think related to is, should we just have a few people that do, the airway team in the department? I've always felt a bit more demic. I've always felt we should, as anaesthetists, all be able to do this. In reality, perhaps in departments it does just get sidled off to people who enjoy it and are comfortable, and there's probably nothing wrong with that. It's just the on-call issues, and people having the insight to know when the case Pierre's talking about, say, right, this needs a fibre optic, and I know someone who loves to do them. So, yeah. Does that answer the question, more or less? Yeah. Yeah. There's very little. There's not much out there, I don't think.
I just make a point for Colin. So in the unit that we're in, we get the anaesthetic trainees to come to the voice clinic. We do about 10 normal voice awake patients just sitting in a chair, and we get them to drive the video nasopharyngoscope in to look at the larynx and hold it still. They have to do it whilst the patient's talking and moving, avoiding triggering gag reflex and so forth. That concept of keeping it in the centre of the field. It's quite interesting. Over 10, they seem to pick up to a pretty good plateau as they go along with that. And that's another area that if you've got any voice clinics or video laryngoscope clinics in your ENT unit, you can send your anaesthetist to. It might scaffold them towards that.
Yeah, and help you. Yep.
If there's nothing else, I think we need to finish up, because the cocktail party's now. There's just one thing I'd like to ask Pierre. You were nearly off the hook. The trolleys, the airway trolleys, is there any moves afoot to nationalise them and have a standardisation nationally?
I think there's
Not
a
putting
lot
you
of
on the spot
vested
at all.
interest from different departments about what constitutes the most appropriate devices, so there'd be a lot of politics involved. Certainly at our institution, we had a reasonable amount of discussion with ICU and ED, all vying for their different components. and to actually standardise it took a wee while. So I think given the personalities of different institutions, there would be some difficulties in some aspects. I think, is that a politically correct way of saying things?
Thank you all. We have some lovely towels that the organisers have given you for your enormous effort. I'm sure it all makes it worthwhile. And just to remind you all that the cocktail party is starting now. Thank you.